Hello and welcome to the first ever session of Toronto Notes 100 Minutes. This is Dr. Ishika, the international medical graduate. I'm working as a clinical assistant right now. I've just done with my licensing exam, so MCQE1 and also the NACOSCI. The reason I'm starting this guideline course is that when I was studying for my MCQE1 and NACOSCI, I also felt that if someone was there to help me or guide me through the Toronto Notes. Each of the chapters, Toronto Notes is a vague book with lots of information in there. But when you have to find those specific information, you have to learn how to utilize Toronto Notes. So I'm going to record all the chapters according to the MCC objectives so that all of you out there, the CARMS aspirants or the ready to practice assessment aspirants, the IMGs who are trying to make it to the clinical field, they can get access to each of the chapters and they can go through them while even they're working 24/7. What I found out that when I was preparing for my MCQ1 is that each of the chapters, if there was something that I could listen to over and over again, or I can go through the pages over and over again, then it actually starts to set in. So my hope and my aim through this guideline would be to guide you that which of the lines of Toronto Notes you have to practice over and over again, because I can tell you that MCQE Part 1 is a very simple test, but the questions are tricky on the basis that it is based on everyday the patients that is being seen at the clinical scenarios. So Toronto Notes is a very good guideline for that. Also, this guideline course will involve the Toronto Notes and also some other resource materials to give a comprehensive look into that. Okay, this is the MCS objectives. This is the guidelines that I should be going through. I can tell you that if you study in that way, you'll be able to revise, you will be able to go to the exam center with confidence. And confidence is nothing but how to utilize your resources effectively. So a lot of us out there who are studying Toronto Notes, we're not getting a lot of us out there who are trying to revise it or who have the upcoming CQE Part 1. This course is a go-to course for you. So this is actually an introduction of how our course will gonna be. So let me just go through what is an MCQE Part 1. So this is the official website, and you can see that MCQE Part 1 is has 210 multiple choice questions and clinical decision making component of 38 cases. So from 2025, as we all know, that CDM portion will be I think that it'll be out, but we're not, like, we don't know the exact how the whole exam will be on that cases. We don't have any official confirmation, like we don't know the infrastructure for that. So this is actually a guideline course for those who will be going for the MCQE1 with 210 multiple choice questions and 38 cases of clinical decision making questions. So let me just show you that how the MCC Part 1 test will be offered to you. So it's gonna give you a score which is not a raw score, and this will be based on these dimensions: so health promotion, illness prevention, acute and chronic psychosocial aspects, assessment, diagnosis, management, communication, professional behavior. So how would you be scored? Let me just tell you a clinical scenario. So there is a patient who is a 65-year-old. Now they're having diverticulosis and it is well controlled, but so they'll come to you at 65 years of age. What should be your advice to that particular patient? So you have to look at the age. So your response will be scored under the health promotion and illness prevention. So for 65 years of age, diverticulosis is well controlled. So that portion is well controlled. So what should be your advice as a physician, as a family physician? Always think yourself as a family physician. You're not a specialist. So your advice for those screening for 65 years of age. So at 65 years of age, if they didn't have any colonoscopy, you have to go for the colonoscopy screening. So the colonoscopy screening starts from 50 years of age. Earlier if there are some certain conditions, and also if they're fit or if it is positive, you can start colonoscopy earlier. But this is the patient that has come to you for the first time, so you have to start with colonoscopy. You have to see whether they have the vaccinations. So if they have the herpes zoster vaccination, if they have the pneumococcal vaccinations, are they smoker, or do they have alcohol habits, how is their mood and stabilities and everything. So these are the things you have to these will come under health promotion or illness prevention. So this is how you'll be scored. So just this is kind of an example. This is kind of a make-out example that this is how you should be studying and you should be approaching any question. So I'm not going to take more of your time, but I'm just going to go through the examination objectives, because this is how we're going to give you the guidelines. Go to the examination objectives at the official website of MCC, then go to the medical expert. Then you can see that alphabetic order, there are MCQ objectives. So this is your go-to syllabus. So let us pick up oligoarthralgia, pain in 1 to 4 joints. So if a patient comes with 1 to 4 joints, that's oligoarthralgia, and then you have to consider all of these conditions, see? So it can be due to injury, infection, it can be due to crystal, hemarthrosis, or acute reactive arthritis. If it's a chronic joint pain, then it comes under osteoarthrosis. If there is a periarticular disease, bursitis, tendinosis, if there is a pediatric disorder, slip epiphysis, osgood-Schlatter, and non-articular disease like bone malignancy and leukemia. So it is very important that when a patient comes with 1 to 4 joints, if it's an acute one, again you have to see if there is any injury. It can be due to meniscal tear, it can be due to infection, any crystals, hemarthrosis, or acute reactive arthritis. Chronic, you go through all of the structure surrounding any joint of that particular joint. So it can be osteoarthrosis, or if it's the tendon and bursa, or if it's a pediatric group, you think about the slipped epiphysis, osgood-Schlatter, and also you can also think of something chronic. So is it a malignancy? Is it due to some other systemic disease like leukemia? So let us pick one today, crystal. We're going to talk about crystal. This is a very, very important topic for MCQE1. Don't go to the exam hall without studying your crystal. So what is a crystal? We go to Toronto Notes, Rheumatology. So you can see this is the crystal-induced osteoarthropathy. So if you can see, the crystal-induced arthropathies is gout, pseudogout. Just remember this with your heart, okay? Because this is the first thing that will come up when you open your Toronto Notes. So the difference between gout and pseudogout. Again, we're going through MCQ1 objectives. So gout and pseudogout, the incidences are very important. So male, it is more on male than female when it comes down to gout. But pseudogout, it's equal. Middle-aged male, postmenopausal female in gout. Pseudogout, elderly. This is very important. And also how the onset occurs. Gout is always acute. It can become chronic if they have underlying disease, if they have renal failure, kidney transplantation, if they have high uric acid that is untreated. So what else can be? That for pseudogout, it is always acute. There are chondrocalcinosis, and it is clinical feature are generally acute. So while I was practicing my clinical medicine back in my home country, I found one girl who's surprisingly, she did have the calcinosis, and there was this acute flare-up of her condition. It involved only one joint, her right thumb, if I can remember. So you see, in that case, it was just a 10 to 15-year-old girl who had this, but it was acute. So yeah, so all the criteria will not be meeting up, but you have to know all of them so that you can have a clue out of it. Also, the crystal type in gout, very important again. This is a monosodium urate. It's a negative birefringence, yellow, parallel, and needle-shaped. In pseudogout, since it's a chronic case, you will find something under the microscope. So it'll be positive birefringence blue, parallel, rhomboid shaped, and the crystal is called CPPD, calcium pyrophosphate dehydrate disease. Okay, and also the distribution of gout, always first MTP, also in midfoot, ankle, knee, or it can be polyarticular. So you see, there are definitive joints here. So first MTP, midfoot, ankle, knee, polyarticular. Okay, so it's like it is only on the lower limb. But when it is pseudogout, it can be knee, it can be wrist, it can be monoarticular or polyarticular. It can be associated with osteoarthritis or rheumatoid arthritis. So gout, definitive pattern. Pseudogout, no, not a definitive pattern. Also, if patient have hemarthrosis, they can also have pseudogout. So radiology in gout, this is non-specific by the way, but you can have erosions. In pseudogout, you can have only chondrocalcinosis, you can have osteoarthritis. Remember, osteoarthritis, they also involve CMC joint, knee, wrist, second and third MCP joint. So as I've told you, if it's a pseudogout, it will involve upper limb. For gout, the treatment is always in acute condition. NSAID is the first choice. Second choice is corticosteroid. Third is colchicine. You have to remember. And also chronic case, there are questions about allopurinol, febuxostat. We're going to come to that later. For pseudogout, you need NSAIDs, the first choice. Second choice is corticosteroid. Remember that. So this is a monogram for common sites of involvement of gout. You see, there's asymmetric joint involvement. It can be first MTP, it can be the knee, or it can be hip sometimes, or it can be the CMC or the first MCP, second MCP. So that is actually not a regular site of involvement, but remember, it can be involved also. This is a parallel section.